Hello, welcome back. Today we are going to discuss MCQs on ectopic pregnancy and miscarriages. Let's go. Regarding ectopic pregnancy, the isthmus of the fallopian tube is the commonest site. B. In vitro fertilization is a risk factor. C. It is excluded by a negative urine pregnancy test. D. Methotrexate is a treatment of choice. E. It is an indirect cause of maternal death. Let's see the stems one by one. Ectopic pregnancy means the outside the uterine cavity. So it could be the ectopic sites could be in tubes or in other sites like abdomen, ovary, cervix, and some surgical scars. Among tubal ectopic, the common site is ampulla. Here you can see it is about 74%. 74%. Next one, IVF is a risk factor. The ectopic pregnancy could be results from multiple causes. So here I mentioned some risk factors for ectopic pregnancy. Especially in IVF, the ectopic pregnancies could be occur due to IVF could be due to some previous tubal problem. So the patient might underwent some tubal surgery. So as I mentioned previously, the ectopic pregnancies can be occurring the previous surgical site. So the IVF could be a risk factor for ectopic pregnancy. It is excluded by a negative urine pregnancy test. Negative urine pregnancy test, that means the strip test that could be positive or negative. There can be false positives and false negatives. So the negative pregnancy urine test cannot exclude the ectopic pregnancy. We have to go with ultrasound scan to see the adnexia, whether there are adnexial masses or there could be some free fluids in the abdomen, pelvis, that could be due to ruptured ectopic. So we have to go with the ultrasound scan. Next one, methotrexate is the treatment of choice. In the management of ectopic pregnancy, there are expectant management, medical management, and surgical management. So, that the management could be expectant, medical, or surgical. Methotrexate is the treatment of choice. In medical management, we use methotrexate as the treatment of choice, but the management option could be different from patient to patient. So this same could be either true in when we in if we consider the medical management, but as overall there could be expectant medical or surgical management. It is an indirect cause of maternal death. This is false because the direct maternal death results from complications directly related to the pregnancy. And indirect maternal deaths are not directly related to the maternal pregnancy. Indirect deaths are related to some previous chronic diseases such as diabetes. Here, the maternal death, here, ectopic pregnancy is directly related to the complications of the pregnancy. Second, a 35-year-old woman in her 10th week of period of gestation presented with vaginal bleeding and offensive vaginal discharge. On examination, the temperature was 102 and the us was open. The uterus was enlarged up to 8 weeks. There was cervical motion tenderness. What is the initial management? Let's see. Here, a 35-year-old woman in her 10th week of POG. The 10th week, that is important because in first trimester that's a common miscarriages are common in first trimester. She presented with vaginal bleeding and offensive vaginal discharge. So, usually the commonest symptom of miscarriage or ectopic pregnancy is vaginal bleeding, and here she is having offensive vaginal discharge. So, in first trimester, the bleeding could be due to miscarriage, ectopic pregnancy, lower urinary tract infection, or H-small pregnancy. As this patient is presented with offensive vaginal discharge, there could be a infection in the lower genital tract. On examination, the temperature was 102. Yes, the patient is having fever about 102. Obviously, there could be an infection in this patient, and the os was open. Os is open means that could be, if it is a miscarriage, that could be incomplete miscarriage or inevitable miscarriage. The uterus was enlarged up to 8 feet. There was cervical motion tenderness. The cervical motion tenderness can be seen in pelvic inflammatory disease and ectopic pregnancy. What is the initial management? Evacuation of the retained products. Before the evacuation of the retained products, we have to check whether there is an intrauterine pregnancy or whether there are retained products in the uterus. C. Obtain samples for microbiological assessment. Yes, we have to uh, collect samples for microbiological assessment as the patient is having fever and with vaginal discharge. Pelvic ultrasound scan. True. Yes, it is true. We have to go with ultrasound scan to see whether there are retained products. E. Serum inflammatory marker. Yes, we have to do inflammatory markers to assess the CRP count and ESR or procalcitonin. But here, here asks what is the initial management. We have to go with intravenous antibiotic therapy first. Mean at the same time we have to take samples for microbiological assessment. The answer is B because the patient is having high fever, about 102. So we have to give IV antibiotic at first. Next one. 28-year-old primey at 6 weeks presented with low abdominal pain and mild vaginal bleeding. She is hemodynamically stable. Transvaginal scan shows adnexal mass with gestational sac and live fetus. What is the management option? Let's primary mother, period of amenorrhea 6. So it is first trimester. Presented with low abdominal pain and mild vaginal bleeding. So in the first trimester, if a pregnant mother is presented with vaginal bleeding, so there could be ectopic, miscarriage, H-small, or lower genital tract infection. She is hemodynamically stable. Okay, now the patient is stable. Transvaginal scan shows adnexal mass with gestational sac and live fetus. There's adnexal mass with gestational sac and live fetus. So this could be an ectopic pregnancy. What is the management option? Patient is hemodynamically stable. There's a adnexal mass with gestational sac with live fetus. So, as I mentioned previously, in ectopic pregnancy management, there are expectant management, medical management, and surgical management. In the medical management, we use methotrexate. But to use expectant manage or medical management, there should not be a live fetus. That means no fetal heart sound. So we have to go with surgery. In surgery, we can go with laparoscopy or laparotomy. In both surgeries, we can go with salpingectomy or salpingotomy. In these days, we go with laparoscopic surgery because it is minimally invasive. Here, so the answer is laparoscopy and salpingectomy. Let's see other stems also. Do quantitative assessment of serum beta HCG. As the ultrasound scan shows adnexal mass with gestational sac and live fetus, so it is obviously ectopic pregnancy, and we do not need to go with serum beta HCG. It is not necessary. Uh, so the live fetus is an indication for surgery, so we have to go with laparoscopy and salpingectomy. A 30-year-old primate at 6th week of gestation presented with abdominal pain and mild PV bleeding. Transvaginal scan failed to show an intrauterine pregnancy. Initial beta HCG value was 1100. What is the next step of management? Okay, let's see. This is a primate at 6th week. So that is early in the first trimester. So the patient present with abdominal pain and mild PV bleeding. So the differential diagnosis for mild PV bleeding in first trimester, as I mentioned, could be miscarriage, could be ectopic, could be H-mole, could be lower genital tract infection. The scan failed to show an intrauterine pregnancy. She is in 6th week of gestation. Scan failed to show intrauterine pregnancy. So this could be a complete miscarriage or still the growing fetus which is failed to show in the transvaginal scan, and this could be ectopic pregnancy. Initial PTHCG value was 1100. Usually, the intrauterine pregnancy can be seen in the transvaginal scan when the beta HCG value is 1500. Here it is 1100. So, as here that they does not mention about whether she is hemodynamically stable or not. Let's consider she is hemodynamically stable. So we have to go with serum beta HCG in 48 hours. In 48 hours, if the beta HCG value is increased more than 63%, so there should be an intrauterine pregnancy. There, we can do transvaginal scan. If it still fail to show an intrauterine pregnancy, that could be a complete miscarriage. If the increase is suboptimal, that means 50% to 63%, that could be due to ectopic pregnancy. If the increase is less than 50%, that means failing pregnancy. However, we have to go with serum beta HCG to further management. CTG is not necessary. Urgent laparotomy is not necessary. No indication here for a laparotomy. IM method said before that we have to confirm whether there is a ectopic pregnancy Repeat ultrasound scan in 48 hours. That does not need. First, we have to go with beta HCG. Next one. 20-year-old primate in her 20th week of period of gestation presented with vaginal bleeding, abdominal pain and faintish attack. On examination, os is open and the products of conception were seen. Ultrasound scan showed a 25 mm gestational sac with no fetal heartbeat. What's the most appropriate cause of management? Here, the patient present in the second trimester, the 20th week, presented with vaginal bleeding, abdominal pain, and faintish attack. So, she's having vaginal bleeding and she's having faintish attack. So, that could be due to anemia, due to blood loss. On examination, os is open. When the os is open, the differential diagnoses are incomplete or inevitable miscarriage. The products of conception were seen. If it is an incomplete miscarriage, the products can be in the uterus. If it is inevitable miscarriage, there can be products seen at the os. Ultrasound scan showed a 25 mm gestational sac with no fetal heartbeat. In inevitable miscarriages, there could be fetal heartbeat or there could not have fetal heartbeat. But in incomplete miscarriage, obviously there is no fetal heartbeat. As the products can be seen in the os, at the os, so we have to go with remove the products of product by a sponge forceps. As the patient is not having any fever and that they doesn't mention about severe pain, so we do not need to go with opioids. Obviously, we do not go with oxytocin infusion. Measure serum beta HCG. As there are products of conception, we do not need to go with serum beta HCG. ERPC, evacuation of retained products of conception and operating theatre. No need, because as the products can be seen, we have to do remove the products by sponge forceps. Then we have to do an ultrasound scan. If it's still the product thickness or endometrial thickness is more than 15 millimeter, we have to do ERPC at operation theatre. Next one. 24-year-old girl has had an early pregnancy loss 10 days ago. Conservative management was offered and bleeding stopped after 2 days. 8 days after, she presented again with fever and per vaginal bleeding to the board. What is the next step of management? This girl had an early pregnancy loss 10 days ago, so miscarriage. Conservative management has done and bleeding stopped. Again, patient presented with fever and PV bleeding. This could be due to retained product, means that could be due to incomplete miscarriage. She's having fever, so the retained product, so that could then it can result in infection in the patient. So the next step of management is we have to provide antibiotics. Misoprostol. As the conservative management has done to this patient, we can go with medical management, but before that we have to treat to the fever. Provision of methotrexate. Obviously, there is no indication for methotrexate here. Immediately evacuation of retained products of conception. First, we have to treat the fever. Then we can remove the retained products of conception of a ultrasound scan. Yes, we have to do an ultrasound scan after providing antibiotics to this patient. 35-year-old lady presented with period of amenorrhea of 6 weeks with mild PV bleeding for 12 hours. Urine HCG positive. Transvaginal scan shows empty uterus. Her blood pressure is 110 by 80 and pulse rate is 80. What is the next management? This lady presented at 6th week, mild PV bleeding for 12 hours. Urine HCG is positive. That means she had a pregnancy. TVS shows empty uterus. So this could be due to still growing fetus or complete miscarriage or an ectopic pregnancy. She's stable as the blood pressure 110 by 80 and pulse rate is 80. So we have to do serum beta HCG. If it is more more than 1500, there should be a intrauterine pregnancy. So first we have to go with serum beta HCG. Here we do not need laparoscopy or laparotomy or no indication for serum progesterone. A 25-year-old woman was admitted with low abdominal pain and mild vaginal bleeding of 2 hours duration at 7th week of amenorrhea. She was pale with cold and clammy extremities, pulse rate 120, blood pressure 75 by 50, and tender lower abdomen. What is the most appropriate step? She is presented with abdominal pain and PV bleeding at 7th week, PV bleeding for 2 hour duration. So there could be heavy bleeding. 7th week, this is first trimester bleeding. I mentioned what are the differential diagnosis. She was pale with cold and clammy extremities. She is having cold and clammy extremities due to bleeding and due to anemia. So her pulse rate is 120, blood pressure 75 by 50. So obviously she is in hypovolemic shock. So what's the first step of management? We have to stabilize the patient. So we have to insert wide bore cannula and take blood for cross-matching. We have to transfuse this patient and we have to provide IV fluids to this patient before anything. During pregnancy test is so we can do that after stabilize. Then blood flow, full blood count. First, we have to stabilize the patient, and the ultrasound scan and catheterization is we can do later. First, we have to stabilize the patient. 35-year-old subfertile women presented with abdominal pain and PV bleeding. Period of amenorrhea 5, urine HCG positive, ultrasound scan shows empty uterus and free fluid in the peritoneal cavity. Blood pressure 80 by 50, pulse rate 100. What is the next step in management? She is subfertile, presented with PV bleeding in 5th week. Now we know the differential diagnosis. Urine HCG positive, so there could be a patient is pregnant. Ultrasound scan shows empty uterus, so that could be due to complete miscarriage or still growing fetus or ectopic pregnancy. And the free fluid in the peritoneal cavity. So the free fluid in the peritoneal cavity can be seen in ruptured ectopic pregnancy. She is obviously in hypovolemic shock because the blood pressure is 80 by 50, pulse rate is 100. So first we have to give IV fluids to the patient. So we have to stabilize the patient. The answer is infusion of IV fluid bolus. The other things can done later. This is the last one. Regarding management of ectopic pregnancy, can be excluded by negative beta HCG test. The beta HCG could be false positive Sometimes if there is too much beta HCG, the test can be negative, so it false. Can be excluded in the absence of period of amenorrhea. Absence of period of amenorrhea could be due to any reason, any ovarian problem, some intrauterine pregnancy, also could be due to multiple problems. Can be excluded in the absence of cervical excitation. Cervical excitation can be seen in not only in the ectopic pregnancy, it can be seen in pelvic inflammatory disease. So that so ectopic pregnancy cannot be excluded in absence of cervical excitation. If hemodynamically stable, can be managed by laparoscopy. Yes, the management of the ectopic pregnancy, as I mentioned, there could be expectant management, medical management, and surgical management. If the patient is hemodynamically stable and if the patient is having beta HCG value is more than 5,000, usually we go with laparoscopic surgery. But if the patient is hemodynamically unstable, we have to go with surgery, either by laparoscopy or laparotomy. So this stem is true